So I did it again. I got carried away. But as I was saying before it cut off on the last audio lecture, the insulin may be ordered because of this high hemoglobin A1C, but that doesn't mean that it's going to be forever. Now, that's really important for some patients because they don't want to be insulin dependent. It was okay for them to have diabetes until it became a problem with insulin. So really important that we help them to teach them patient education on the lifestyle changes that they need to make. As we get into talking about the anti-diabetic drugs, you're going to see the types are the insulins and then the oral hypoglycemic agents. Now, the patient may get both of those with the aim of producing normal blood glucose states. Some of the new injectable hypoglycemic drugs may be used in addition to insulin or anti-diabetic drugs. And we will see many on the market. We have the new Ozempic that's advertised, the Trulicity, our incretin mimetics, our GLP-1 antagonist, receptor antagonist. I mean, there's just all these new medications that are coming up on the market. And every time you turn around, it seems like they're developing a new one. So let's do some critical thinking about that. Why do you think that is? Oh, probably because, right, we know that the CDC says that we are going to have more diabetes because of our standard American diet and because we're not making these lifestyle changes fast enough and because we had this wake-up call about childhood obesity, and the potential for the younger generation to be the first generation in history that dies of diseases at a younger age than their parents or before their parents are gone. So the drug manufacturers have jumped on there and are helping us by developing these new drugs that will help to conquer diabetes. So let's talk about these drugs. Now, obviously, we've had insulin a while, and human insulin is chemically identical to the endogenous insulin, but it's not derived from the human pancreas. So you will hear about pork insulin, bovine insulin, and human insulin. And so sometimes people are like, oh, I don't want human insulin. And then sometimes they'll be like, oh, I don't want pork insulin. But understand that human insulin is just a chemical structure. It's derived using a recombinant DNA technology, and then the recombinant insulin is produced by the bacteria and the yeast. Obviously, insulin cannot be given orally. And the effects of insulin are the same as the normal endogenous insulin. Whether it is a human insulin or pork insulin, the effects are the same. So what it does is it restores the diabetic patient's ability to metabolize the carbohydrates, the fats, and the proteins, to store that glucose in the liver, and then to convert the glycogen to the fat stores. Our types, when we look, the rapid acting is for the treatment of types 1 and type 2 diabetes. It has a rapid onset of action, 5 to 15 minutes. So the patient has to eat after this is given. It's going to peak in about 1 to 2 hours with a duration of 3 to 5 hours. But if they don't eat, you're going to have a significant problem. This is our insulin called Lispro or Humalog. It's similar to the action of the endogenous insulin, our insulin Aspart or Novolog, and Apidra, or the insulin glucine. They can be given subcutaneously or via a subcutaneous infusion pump, but not intravenously IV. Now, Afrezza, this is a rapid-acting insulin that is actually inhaled. It has a peak onset of 12 to 15 minutes. It has a short duration of action, only about 2 to 3 hours, and it must be administered within 20 minutes before each meal. It has to be given in conjunction with a long-acting insulin or an oral anti-diabetic agent for a type 2 diabetic. Side effects include hypoglycemia, a cough, and throat pain. It's an inhaled, so that's a side effect that could occur. It is contraindicated in smokers and those with chronic lung diseases. It also has a black box warning regarding the risk of acute bronchospasm. So what chronic lung disease would you be very careful that you not give to, and I'm thinking particularly in someone who might be a child. Think about that. See if you can put that on your to-study list. Our other short-acting insulin is our regular insulin. Now, this is our insulin that we will use for IV infusion or IV bolus. We can also give it IM or sub-Q. Onset subcutaneously is 30 to 60 minutes with a sub-Q route. The peak is 2.5 hours with a duration of 6 to 10 hours. An important thing to note about IV infusion or IV administration of regular insulin is that insulin will line the tubing. So you need to make sure that there is an insulin that you have enough insulin in the tubing, in the infusion or in the drip, to make sure that the patient is getting all of the insulin that's supposed to be getting, because it will adhere. So it needs to be primed completely before your patient is going to get any insulin. So that's an important thing to know about IV insulin, is that it does adhere to the sides of the IV tubing. Now, when we have insulin dosing and syringes, they're pretty standard. U100s are pretty standard for most of our 100 unit per ml insulin. With our insulin pens, however, you're going to have a U200, a U300, or for those newer concentrations, when we have patients that need very high doses, there is a U500 pen. So those are pens. Now the syringe is still the U100. You will occasionally, particularly if you're working in some of the less affluent or an indigent area where you might not be getting a standardized, you're getting donations or you're getting something where you're working with different systems, you may get a U50 syringe. So it's still units. Just remember, you always measure it in units. Even though it's 100 units per ml, you never use mLs. You always use a unit syringe for insulin. And they are universally around the world with an orange cap. So that's just a couple reminders from LVN 111. Intermediate acting insulins. This is our insulin isophane suspension. It's also called NPH. It has a cloudy appearance. It is often the one that can be combined with regular insulin, although with our newer insulins, we're not seeing this nearly as much as we have in the past. Onset is 1 to 2 hours, peak 4 to 8 hours, and a duration of 10 to 18 hours. Then we have our long-acting insulins. This is our insulin glargine, our Lantus. It's a clear, colorless solution. It helps to maintain a constant level of insulin in the body. It is often referred to as basal insulin. It's usually dosed once a day and often at night. So it's done in the evening. It can be dosed every 12 hours if necessary. But we usually will do a 24-hour unless we have a really high A1C that we're trying to get down, or we have a person who's out of control. We may either increase the Lantus to every 12 hours or add a regular insulin to the, not to that, you can't combine them, but to the regimen and have them do a regular insulin maybe in the morning after breakfast or depending on the patient. So it will be onset for the Lantus is 1 to 2 hours. There is no peak with this, but the duration is 24 hours. When we look at these long-acting insulins, we know that Toujeo is more concentrated. It is a U300 pen that comes in. So when you are pulling these, if you have work in a clinic where they have samples or they give the patient a starter pack, you want to make sure you're pulling the correct insulin, because your U100 pen or your U300 pen or your U500 pen is going to be very different depending on what the patient is getting. So you can't just switch out one for the other necessarily. You want to make sure that you have the right insulin. Our other long-actings are Detamir or Levemir. Its duration of action is actually dose dependent, and so it's lower dosing, and it requires twice daily dosing because of that. You can give higher doses once a day, but it's usually we're going to give it twice a day. With our glargine Basaglar, this is a biosimilar insulin, and it is usually it's a U100 insulin. And then there's Tresiba, which is available in a U100 or a U200, it is an ultra long-acting insulin. So it is a once daily dose. With our fixed combination insulin, this is our Humulin 70/30, 50/50, our Novolin 70/30, our Humalog mix. Ironically, these all come now as fixed combinations for us. We don't mix insulin like we did years ago very, very often. It's pretty rare. It still does happen sometimes, but these are fixed combinations, and it helps the patient to have both that peak that occurs right after the meal and then that longer peak that occurs later. So each of the fixed combinations have two different insulins. They're already mixed. There's an intermediate type and then a rapid acting type. So they'll have either a Humalog or a Novolog, or one short acting type, the Humulin. With the sliding scale insulin, you are looking at a sub-Q rapid acting, either a Lispro or a Spart, or a short acting regular. Most of the time, it's going to be regular simply because it's less expensive. But not always. Just depends a lot of times on the insurance and the clinic or hospital where you're working. But with sliding scale, what happens is it's adjusted according to the blood glucose test results. So typically in our hospitalized diabetic patients, or those that are on TPN, or maybe they have a tube feeding, they're going to get this sliding scale insulin. You'll also see it used in surgery patients. Maybe they need a little bit more insulin control, or they can't take the oral medication that they typically take because of testing. There are some interactions with testing for some of those drugs. And so you will be giving a sliding scale dose. It's ordered in the amount that increases as the blood glucose increases, which is why it's called a sliding scale. As the patient's blood glucose goes up, the insulin given goes up. As the blood glucose goes down, then the insulin goes down. The disadvantage of sliding scale is that it delays the insulin administration until you have the hyperglycemia. So you get these larger swings in glucose control. So it's not as good an option, but it is a good option when you really need it, and when you need when you can't give other things because you've got some of the other complications going on, like a TPN or tube feeding or a surgical patient. With our Basal bolus insulin dosing, remember, this is our long-acting. Basal insulin is our long-acting insulin. That's our glargine. Bolus insulin is going to be either the insulin Lispro or the Asparte. And this is the preferred method of treatment for hospitalized patients who have diabetes. And when they're there with, whether it's diabetes ketoacidosis after they're off of a drip or things like that, because the reason it's preferred is it mimics a healthy pancreas by delivering this basal insulin constantly as the basal, and then we get the bolus as needed, like a bolus, just like the pancreas would do. It would secrete enough insulin to keep a steady glucose. Then when we introduce more and glucose and we have a higher elevation, the pancreas, right, spits out more insulin. So that's why it mimics that healthy pancreas. So we're starting to see the basal bolus insulin dosing used more and more. With our oral hypoglycemic agents, there are 5 types that we use to treat diabetes. Our sulfonylureas are the oldest ones. They increase the release of insulin and decrease the production of glucose in the liver. So they increase the number of insulin receptors and increase the peripheral use of the glucose. But the oral hypoglycemics are only effective if we have functioning beta cells. So effective treatment with the oral hypoglycemics include several elements, and that is that we have to be careful with the monitoring of the blood glucose levels. There may need to be therapy with more than one drug, and the treatment of the associated comorbid conditions like the high cholesterol or the high blood pressure need to occur. The primary side effect of the oral hypoglycemic agents is hypoglycemia, and we'll talk about that as we talk about these agents in greater detail. We're almost to the end of this audio lecture, so I'm going to go ahead and switch over, and I'll see you in a few minutes.